As you
Dr.
prefer.
Simarro, Michelini suggested that we start with Simarro,
Okay.
and then
Okay.
we're about to go live. So we'll be live in about 20 seconds. So
Wait
now
a
you have to
moment.
smile all the time.
That's better now. So can I share the TV the TV? How can I share the TV now? Hmm. Let me see. How
Yep,
is
it's
to share?
on the bottom of your screen, and you'll be
Yes,
perfect.
I'm looking for it, but where is it? Opciones to share.
The green, the
Walk
green.
along.
I'm looking for it, but I can't find it. Let me see. No. Ah, here is it. Wait a moment. No, this is not. This is in Spanish. No, this is not. This is in Spanish. And I want the English version.
Maybe, Kate, we can start to introduce the guests.
Yeah, why don't we do that? Let me just
we are live.
Here is it. Clinical diagnosis of lipedema. Can you see it? Clinical
Yes,
diagnosis
perfectly.
of lipedema. Okay, that's the English version.
Okay, can we start?
Yeah, go for it.
Okay. Thank you very much for being here, and welcome to this Lipedema Awareness Month event organized by the LWA, Lipedema World Alliance. Thank you so much for our amazing organizers. Thank you, Kate. Thank you to Lipedema UK and Unlift and all our friends that are putting a lot of effort in organizing this amazing event and meetings with our healthcare professionals. So tonight we are going to listen to precious contribution by two amazing doctors that are part of the LWA board. And we are introducing, I don't need, they both need, I don't think they both need any, any presentation from me because they are all well known. But tonight, Dr. Jose Luis Simarro from Spain and Dr. Sandro Michelini from Italy are going to talk about some very important things on lipedema. And so I'm briefly introducing our speakers, and I am Valeria Giordano, president of Lio Lipedema Italia, and nice to see you again. Dr. Simarro, what to say about you? You were qualified since the 80s. You have an astonishing experience and career in taking care of we patients with lipedema. And you were the director of the Istituto di Lipedema from, maybe correct me if I'm wrong, 2007 to 2022. You have an amazing expertise in a lot of fields of medicine and diet, nutrition, cosmetic surgery, and you were a presenter in so many international conferences, and you are a real true pioneer of the conservative treatment for lipedema, so non-surgical solution. So you are the director of the Clínica Simarro in Madrid and Barcelona, and the field is yours, Dr. Simarro. Thank you very much. You're going to speak about clinical diagnosis of lipedema and your amazing classification that we all want to know about. Thank you.
Well, thank you, Valeria. Thanks to everybody in the Lipedema World Association to permit me to participate in this webinar. And I'm very happy that to explain everybody what we have discovered from the beginning of the Institute of Lipedema. The Institute of Lipedema was founded in 2007 when we began to diagnose lipedema. So we are studying and study and investigated in lipedema about 17 years ago, I think, that we began to investigate. And I remember maybe in 2010 or more or less, when I made a diagnosis of lipedema, the doctors that read my diagnosis used to say, what, this, he has mistake, and this is lymphedema, or this is a disease of aesthetics doctors, or something like nobody knew what lipedema was then. But I have founded the Lipedema Institute, and I was advancing in the diagnosis and in the treatment. And as you have said, we have developed non-surgical treatment different than compression or any other things. It could be between the chirurgic treatment and the conservative treatment. That this is other words, and we're not going to speak about that tonight. We're going to speak about what we have discovered in the diagnosis of lipedema. Because at this moment, the diagnosis of lipedema is just based on what you see. This is a clinical diagnosis. You see, today the diagnosis of lipedema is made by the clinic. You look, you touch, you ask if it hurts, and that's all. There's not a diagnosis by echography, as we do. There's not a diagnosis for hematologic or DNA that I have Sandro will tell us something. At this moment, the diagnosis is just clinical diagnosis, and that's not very good because what one see, the other can see in other way. So it's very, very difficult to diagnose only what you see. And there are two problems. First, the beginning of lipedema does not know that when the lipedema begins, it's very little. So how do you diagnose it with the clinic? And when the lipedema advances, it's always associated to obesity. And much of us suspect that when the lipedema advances, the half upper body is affected by lipedema, and it looks like obesity, but that's not obesity. That's lipedema that has affected all the world. I repeat, this is very discussed, but that's what we think. Because if you see the development of the lipedema in the years and the years, you see how it began and you see how it finished. And you see that it finished in lipolymphedema and obesity. So why that's that? Because we think that lipedema, especially when the menopause arrives, goes to the upper part of the body. So it's very easy to mistake a lipedema with obesity, but they are completely different. So at the moment, the problem with diagnosis of lipedema is that it's only clinic. Then we have developed many things that permit to differentiate the lipedema with all the other diseases. The current clinical classification is in type and studies. This is type 1, type 2, type 3. You see type 1 are the hips, type 2 are the half part of the legs, the half upper part. Type 3 is all the legs. Type 4 are the legs and the arm, and type 5 would be lipolymphedema, in where you see that the feet are affected. Those are types described. Those are the types, and these are the estadios. This is the 1, 2, and 3 stadios. But the problem that it does not correspond to the intensity of the painful symptoms or accompanying disease or other situations. So you can have a study 1 and you can have a type 2, but the pain can be very big. And you can have a type 4 and a study 3, state 3, and you have not pain. So why is this? Because this classification is very ancient, and at this moment we think that it's not real, and many of us know that the pain and many other symptoms doesn't mismatch with the pain and the disease that the patient have. Those are the differential diagnoses at this moment when you see a woman. Primary lymphedema. What primary lymphedema? Because the lymphedema primary affects both legs. Then, if both legs are swollen, you can say, oh, that's lipedema, but this is lymphedema. But it's not difficult to differentiate because the lymphedema, the primary lymphedema, you're born with it. So when you're young, you have your legs swallowed, and then you see that it doesn't develop as usually in the lipedema in the puberty. Secondary lymphedema is usually in our countries, in Europe and the United States, due to a post-surgery where you have taken away the lymphatic part of the body, of that leg, of that arm. It's very easy to differentiate. It affects only one leg, only one arm. Lipohypertrophy. What is lipohypertrophy? Lipohypertrophy is when the fat grows, but it's not pathologic. Sometimes lipohypertrophy, its diagnosis as cellulite. I want to say cellulite is what the OMS, the World Organization says as cellulite, but usually it's called cellulitis. That's not true. The name is cellulite. Well, lipohypertrophy is the growth of the fat in the legs, but it's not pathologic. And many of us think that the lipohypertrophy could be a beginning of lipedema, or maybe a lipedema without pain. The next one is lymphedema due to primary venous involvement. Time ago, it was called phlebedema. At this moment, we don't think that phlebedema, that was affectation of the return of the venous, always goes with affectation of the lymphatics. So this would be a lymphedema, but different to the other lymphedema, because the trigger is the venous damage that would disencadenate, would trigger a lymphedema. But the beginning is venous problem. Next one is obesity. Obesity can be mismatched with, can be confused with an lipedema, advanced lipedema, but in the obesity, it's not usual the pain. And obesity respond to the diets, and obesity respond to the exercise, while the lipedema doesn't respond to diet and exercise, usually. And the last one is oil. Oil is obesity-induced lymphedema. This is a kind of lymphedema that occurs usually when the VMA is higher in morbid obesity, but sometimes in other kinds of obesity, you can see oil, and it can be similar to lipedema. But in those countries where the obesity is very common, the big obesity, it's very difficult to differentiate obesity-induced lymphedema with lipedema. And we think that maybe they are sometimes the lipedema with obesity makes also an oil, and you have lipedema and oil. Well, we have developed a new classification based on the hypothesis of the subcompartment syndrome of the saphenous compartment. We will speak just a little about this hypothesis. For us, it's not a hypothesis, and we're making an investigation to demonstrate it. And I can tell you that is very advanced, but it's for other moment. We have not time now. But what is subcompartmental syndrome of the saphenous compartment? This is the saphenous compartment in the leg. The great saphenous compartment, you see that is an special of compartment where the saphenous vein goes from the up to the down part of the leg. In the leg, we have two types of fat. Superficial fat, fat is adipose tissue, superficial adipose tissue. Well, you have one part superficial adipose tissue, deep adipose tissue, but here in the leg, inside the leg, you have a third compartment that is the saphenous compartment, and this saphenous compartment has two fascias, and inside it has a lymphatic, a venous, and a nerve. Saphenous fascia is this one, and muscular fascia. And why this? We think that the saphenous fascia works like this. When you walk, the muscle is elongated, the fascia is stretched and compressed the venous and lymphatics. And as the venous and lymphatics has valves, this compression makes a return of the lymphatics and in the vein through the up of the saphenous compartment and to the heart. So we think that this works like this. And what's the matter in lipedema? In lipedema, inside the saphenous compartment, the fat grows up, but not only grows up, it becomes fibrotic. And then when you walk and you stress the fascia, it doesn't work. So if it doesn't work, what matter will be this one. You see, this is the normal. You see how the tube brings water. But if you lose the dryness here, the dryness stops, not at all, but a little, and due to the gravity, it dilates in the downside. So what we think is this what's matter, and that's what explains how many people with lipedema says that over the ankle, they become bigger and bigger during the day due to the orthostatins, and during the night, as you are horizontal, then you lose the water, and when you wake up, you have again ankle. This is our hypothesis, due that the saphenous compartment doesn't drainage lymphatics. Well, based on this hypothesis, we have described two different types of lipedema according to its onset. Type I lipedema, Heinz phenotype, increased volume in the thighs at puberty. Little pain because subchronic compartment syndrome. What affects in this lipedema is superficial SAD specifically and deep SAD, but not saphenous SAD. So it's big, but there's not saphenous compartment. But type B lipedema is completely different. What is affected is saphenous SAD. So it's not very big, but it makes rapidly subchorionic compartment. Then the beginning is here, is in the ankle. It looks like tubular appearance and would justify the lipedema appearance before the puberty. Before the puberty, everybody speaks that the lipedema begins in the puberty. We don't agree. And there's a publicated paper of a children's hospital from United States that has demonstrated that lipedema can begin before the puberty. Then here are the two types of lipedema and the development of this lipedema. Lipedema type A appears with puberty. It's initially located in the tights and usually non-painful. It's just up, and this could be lipohypertrophy at the beginning. The patients only notice that she wears a large pants size than her friends, but this is between 13 and 18 years, and no more, just boom, no pain, no other thing. It's very common to buy diagnosis with cellulite. The treatment prescribed for cellulite fail, and the patient observes that the increase in fat in the thighs continues even with diet and exercise. With older age, the increase in fat mass will begin to affect the lower of the leg, the calves. You will begin to notice tightness and discomfort in the area above the ankles, and at the end of the day, increasing with menstruation and heat. In addition to the tightness, you might notice an increase in volume in the area above the ankles. The saphenous compartment syndrome is beginning. Later, 37 to 48, lipedema will progressively increase volume through the leg, and pain and congestion can increase. It will also be possible that you will begin to notice an increase in volume in your arms, in the posterior arch area, and also sagging in this area. However, lipedema usually, until the beginning of menopause, will not affect the upper half of the body. This is very common, but this is other type. Lipedema type B. This is Moncorp's. It has been, there's some papers that speak about the Moncorp's rusticanus. We call it lipedema type B. This type of lipedema often has its onset before puberty or in the early years. In many occasions, if you ask the patient remember that when she was 8 or 9 years old, before the puberty, before the estrogens, and before her first menstruation, she already noticed that the area above her ankles were slightly thickened, even taking on a tubular appearance. If she wore short socks or high boots, they could leave mark in this area above the ankles and will notice tightness in this area. With the arrival of menstruations in this type of lipedema, the ankle and sometimes the entire lower half of the leg take on a tubular shape, especially on menstruation on hot days. Pain, congestion, and discomfort in the lower part of the calf and on the ankles begin already the age of 12 to 14 years, earlier than in type A lipedema. This is very important, what I am going to say now. Since the condition has reached present since childhood, it's not uncommon for this type of lipedema to produce psychological alterations. Sometimes the zinc-alkyl complex during puberty can lead to psychological damage, especially eating disorder, because they have his brain maturation with this problem. And this is important. It's not the same a woman with 16 or 18 that sees that his legs are very little bigger, but not more, that when they were 8, because from 8 to 14, when they are developing his personality, they don't want to show the ankles. They have difference, and they try to lose weight, and they get eating disorders. In this kind of lipedema, in our experience, is where the eating disorders are more usual. With the passage of some years, but not always, the lipedema will extend and affect the types, confusing it with type A lipedema. But venous and lymphatic damage since childhood will cause pain and congestion on the thighs. The ankles are larger than in type A lipedema. Like type A lipedema, over the years, the arm may be affected, and shortly before or already during menopause, lipedema will affect above the waist. It's very common for this woman with lipedema, this type of lipedema. So the thin lipedema is much more common to be a type B lipedema. And if we see a lipedema thin, we must ask how you was when you was 8 or 9 years old. Do you feel something in your ankles? Do you wear only pantalones, trousers, because you didn't want to show your ankles? It's important. At this moment, we make to all of them test of eating disorders from the last 1.5 years, and we are looking that this kind of lipedema has a lot of times eating disorders. Well, we have seen this, and now some pathologies let's begin with the clinical diagnosis. Some pathologies, such as fibromyalgia, are diagnosed through the evaluation of painful press board. There's not other diagnosis at present in fibromyalgia. But many people think that that's true and it can be diagnosed. At this moment, the same like lipedema, there's not biological markers of fibromyalgia, just are painful points. Based on this premise, we have developed something similar. Symptoms and signs of lipedema developed at the Lipedema Institute. First one, painful points. The painful points will be due, we have seen that in the saphenous compartment, there is a nerve. In this case, in the bigger saphenous compartment, will be the saphenous nerve. This nerve, due to the inflammation and compression, will develop a special kind of affectation who is called neuroapraxia. Neuroapraxia is not diagnosed by any other things like, for example, electric impulse and other things that you can diagnose. Neuroapraxia just will be pain. And there are points where if the nerve have problems, the pressure in the saphenous compartment will be especially painful. Those are painful points. See my hand. The painful points, you have to put your hand like this, no pressure like this. It's like this. This is very, very important. See my hand and see this are the painful points. Why this one? The painful points are those in blue. This is the 3 painful points in lipedema. I think that even in Italy, there has been called Simarro points of lipedema or something like. Really, it could be called. These painful points are subcondylar, supracondylar, and supramalleolar in the saphenous compartment. And why in this order? Because the subcondylar is the more painful, the supracondylar is the second more painful, and supramalleolar is the third. And sometimes, if there is not venous and lymphatic damage, the pain in the supramalleolar can be little. But this one, subcondylar or infracondylar, The only disease that they feel pain is in lipedema. No one of the diseases we have speak has pain in this point of pressure. This is important, but you have to do it well. Remember, this is how you have to press. And these are them. Look at me. This is how you have to press, because remember that the saphenous compartment is in the deep. You have to press deep in this part. And people with lipedema say, oh, I feel a lot of pain. You can make the same thing in other place of the leg, and they will say, no, I have no pain. But in this place, they will say, oh, it's very, very painful. And remember, 3 points. 1, 2, and 3. Always in order, in this order. This is the one. Second, see my fingers, how I press the deep. And this is the last one, and see how I press the same. The next one are painful areas, also with deep depression. This is the saphenous compartment, and in red will be then the saphenous nerve. If you press in the greater saphenous compartment, deep compression, as I show you, they will tell you that they feel pain in all the saphenous compartment. But curiously, the saphenous compartment finishes here. I don't know if you see my mouse. Valeria, can you see my mouse? Well, this is very important.
You can.
Because if you press the saphenous compartment, it's danger. But if you press here, they say no pain. If you just change 10 centimeters, if you just change here, they say it pain. And here they say no pain. Why this change? Because the saphenous compartment finish here, no here. And they say pain and no pain. The lesser saphenous compartment, I have no a picture at this moment, but it's very similar. It's in the lower leg, and the postbrachial compartment is this one, the one that is in red. The posterior brachial compartment against the saphenous compartment is very, very superficial, and the nerve is the musculocutaneous nerve. So here, the pain will not be in the deep, will be very, very superficial. You see? Very, very superficial. And remember, it goes where the red line goes. So if you press just very, very little, very, very superficial, they will say, yes, I feel pain. And if you press deep, they will say no pain, because the posterior brachial compartment is superficial. Then, when the fat grows inside this compartment, the leg goes, the arm goes down immediately. That explains why in the arm, immediately when they get fat, goes down.
Dr. Simarro, apologies to interrupt you. You have a couple of minutes to conclude. And I'm
Yes,
so sorry
finished.
because what you were saying is so amazing and so interesting.
Next one is the thing of face puncture. Here you see how is a face puncture. You have not to puncture, just to touch. And in these thumbs, they will feel as if you were puncturing. You doesn't punct, but they will feel it. And look this, and look at this, and also in the brachial compartment. And this is, and at the end, with this finish, there is a loss of fine sensitivity at the pertrochanteric level. What's that? This. And touching with a paper, very smooth. But they say that in all this part in red, they lose sensitivity, but they find sensitivity. And when you go out this part, suddenly they say, now I feel. but not here. So if you touch with a paper or something like very small, they will say, I lose sensitivity here and I gain again sensitivity here. And that's all. I have finished.
Thank you so much, Dr. Simarro, for this amazing presentation. I think you discussed some very revolutionary ideas because it's a long time that we're discussing on how it is important to change the classification and stages of lipedema because they're only based on where lipedema is localized on our bodies and the voluminosity of the adipose tissue limbs. But having a classification that is based on symptoms is the way we should go, definitely, to help all the doctors and all patients to describe what is on their bodies, because we have people at 3 stages of lipedema with very few pain, and we have people at stage 1 with a lot of pain that are considered, you're only stage 1 where you're complaining about pain. And so this is very revolutionary. Thank you so much for this super informative presentation.
Thank you.
Are we going to introduce Dr. Michelini, Kate? Perfect. So Dr. Sandro Michelini is our president, is the president of the LWA. And thank you so much also to you, Dr. Michelini, for being here tonight with us. Also, you don't need so much presentation because you are a well-known name. And Dr. Sandro Michelini dedicated maybe over 40 years maybe to vascular diseases, lymphedema, lipedema, and all the related pathologies. So Dr. Michelini is a passionate researcher, spent decades to knowledge sharing of his own clinical experience, and he took part also in several research projects. And one of the most important one is the one that discovered the first gene mutation in lipedema. So Dr. Michelini is also always committed in institution and nationally and internationally with scientific societies, with the Ministry of Health. He is a very pioneer of helping us having the lipedema recognized by the national health system. And he's also always committed to involve patient association. So thank you so much, Dr. Michelini, for all you mean to us in Italy and now in the world. The stage is yours.
Thank you, Valeria. First of all, I would like to congratulate with Jose for his very clear and complete presentation. We discussed about on Sunday about this possible evolution of our presentation. And good evening to all of you. You well know that interest in lipedema is constantly and strongly increasing worldwide. In the last 15 years, but especially in the last 5 years, literature has literally exploded on the subject. And in the current year, it is foreseeable that 1,000 articles devoted to the various aspects of this disease will be exceeded. The disease, as just said by Jose, which was only in 2022 recognized by the World Health Organization as such with its own reference code, is characterized by an abnormal asymmetrical accumulation of subcutaneous adipose tissue in the limbs that does not respond to the adipose tissue's common self-regulating mechanism. This is very interesting. Low-calorie diet, exercise, and even bariatric surgery in its various techniques have no effect on this pathological accumulation. As regards epidemiological data, we have no certain information But according to several sources, the disease seems to affect about 10% of the female population, with only rare male cases. The etiology is also not yet well defined. The genetic hypothesis, for which I present some preliminary data, is supported by the fact that the disease is present in at least 100 cases in the family, and by the discovery by our research group of the first genes, as remembered by Valeria, responsible for the disease, if mutated, linked to the metabolism of female sex hormones, in particular progesterone. The role of hormones seems justified by the clear preponderance of the incidence in the female sex and the clinical onset generally at puberty. The relationship with obesity, which is often present in these cases, is unproven and inconstant. As you can see in this 4-generation pedigree, the disease is present in some female subjects, as you can see in the more generation. Interestingly, in some cases, the transmission of the characters occurs through the male, as you can see in this family pedigree, who turns out to be an healthy carrier, transmitted but does not become ill. This mostly does to look for familiarity always also among the female figures in the paternal family. This is very important. The common clinical aspects of the disease are represented by familiarity, onset at puberty, accentuation with pregnancy and gynecological surgery. The distribution of fat occurs essentially in buttocks, thighs, and legs for lower limbs, in the arms for the upper limb. There is a clear the demarcation between the diseased tissue and the healthy tissue, and the ankle and the wrist with saving of the feet and the hands. The development of the disease is simultaneous, bilateral, and symmetrical. Spontaneous hematomas in the affected limbs are frequent, but pain is also present, and usually it is accentuated as the day goes on. In this connection, we are studying, for example, the concentration of pregnenolone sulfate, which seems to have, when highly concentrated in the serum, a protective action against pain itself. Conversely, it is revelated with low concentration, at least in the first preliminary study, in patients with greater pain perception. This is important to deep as clinical aspects. Comorbidities associated with lipedema are observed in clinical practice. These include insulin resistance, autoimmune thyroiditis, articular inflammation. Remember the insulin resistance. After we speak about some genetic mutation regarding these aspects, articular inflammation, low vitamin D levels, hypermobility, joint disruption, and endometriosis and polycystic ovarian. I would like, for this occasion, present to you several ongoing studies in collaboration with the Magic Genetics Laboratory in Rovereto in Italy, with which we collaborated, the Anatomy Institute of the University of Ancona, and the Biochemistry Institute of the University of Catanzaro. The study, which is still ongoing and of which I am presenting some of the preliminary results, was conducted on 22 volunteer patients presenting with type 2 and type 3 lipedema at clinical stage 1 and 2 with body mass index in the normal range. Tissue was taken from these patients in the affected area, inferomedial third of the thigh, and in the healthy area, tissue taken from the back. The tissue samples, together with a saliva sample and a strand of hair, were sent to the 3 aforementioned laboratories. Analysis, some which were still ongoing, involved the study of genetic, germinal, and somatic mutation, of anatomical sample with light and electron microscopy, and the biochemistry on selected tissue microRNA. In particular, the biochemical study was carried out on 800 microRNA, of which 787 were coincident in the two tissue, in the health and the illness, the tissue of the illness. 15 were different, 3 of them very different, and 1 was particularly biologically active. So much so that we are also verifying its presence in the patient serum to define its possible role as a disease marker, because still today the diagnosis of lipedema is only clinical. Still today we have not an official marker to define the pathology. Regarding the genetic aspect, specifically, we found the genetic variants in some gene. You can see the gene. This mutation previously identified in related studies in tumors and vascular malformation, lipomas, and lipodystrophies are essential for understanding the genetic alteration associated with lipedema. Anatomical studies have in particular shown an average increased volume up to doubling of adipocytes compared to those in healthy areas, with a noticeable increase in vascularization, in particular of pericytes, which could be pre-adipocytes, an increase in collagen fibers, and noticeable calcium deposits in endothelial cells and affected adipocytes. Calcium, as you know, inhibits intracytoplasmatic phospholipases, and in this sense could contribute to the increase in intracellular lipid deposits, resulting in increased cell volume. In this slide, you can see the pathological essential elements of the adipose tissue capillaries of lipedema compared with the lean subject. It is evident that in the affected tissue, the area, as you can see, is a thickening of the wall with an increase in endothelial cells and pericyte. The same size of the adipocyte is significantly increasing the pathological issue, as you can see in this diagram. And if we compare the affected area with the unaffected area, in some cases, the cell have, as just said, a double volume. More papers demonstrated that the progesterone receptor is well present in the pre-adipocyte in the subcutaneous tissue. But what does progesterone do on pre-adipocytes? It stimulates the development, determination, and differentiation of the pre-adipocyte. Progesterone plays a role in regulating cellular calcium, modulates calcium channels. Calcium deposits could also be linked to the first gene discovered by us, the AKPR1C1 mutation, which determines the increased concentration of progesterone activity. Von Cossa is a specific histochemical technique for identifying calcium, of which there is a lot in the affected areas, as you can see. All the deposits of calcium in the cells of affected area. Calcium inhibits intracytoplasmatic phospholipases, and in this sense could contribute to the increase of intracellular lipid deposits, resulting in an increased cell volume. Somatic mutations are changed to the DNA that happen after conception to cells other than the gametes. Somatic mutations have been correlated to the development of adipose tissue-related disorders. The somatic genetic study on the submitted samples technically very difficult to carry out for DNA analysis from the somatic and non-germinal, revealed somatic mutation of the cited genes. In particular, the gene PDGFRA mutation promotes fibrosis of adipose tissue, which in turn promotes changes in the plasticity of vascular progenitor cells, suggesting a possible connection with a syndrome recently described as FAVA, fibroadipose vascular anomaly. The involvement of perivascular adipose tissue, as shown in recent studies, suggests a possible connection in the creation of an unifying model with perivascular adipose cells. The somatic mutation identifying PARG and other genes is of particular interest as it is responsible for the Warburg effect and insulin resistance, providing a further key to understanding the metabolic alteration associated, as said, with lipedema. In the pathogenesis of lipedema, there is therefore an hormonal influence, perhaps also thyroid. The vessels represent laboratories for the production of adipocytes. The increase in adipogenesis is therefore linked to vascular and consequently metabolic alteration. The increase in intracellular calcium determines a decrease in lipolysis and the consequent increase in volume of adipocytes. The hypertrophic adipocyte is stranded and dies. This phenomenon ultimately translates into an increase in inflammation in a cycle that then becomes vicious. As widely acquired in the literature with regards to primary lymphedema, a condition of different syndromic picture is also emerging for lipedema, which have in common the anomalous accumulation of adipose cells in certain body regions, cells which do not respond to common self-regulation rules of adipose tissue. The most common syndromes can be identified as lipedema with variable but intense painful symptoms, lipedema with insulin resistance, lipedema associated with autoimmune manifestation, above all Hashimoto thyroiditis, as you know, lipedema with associated female endocrinological pathology, like endometriosis and polycystic ovary, and lipedema with hypermobility. Often the Ehlers-Danlos syndrome is associated with lipedema. Lipedema is easily misdiagnosed, but a timely and accurate diagnosis is essential for early intervention and treatment of the disease to prevent the clinical development. In the genetic analysis of lipedema, it is necessary to develop a next generation sequencing new techniques panel comprising many genes that may be important for the differential diagnosis of lipedema, as well as candidate genes that could be involved in the etiopathogenesis of lipedema, just to avoid, if we well know, the development of the pathology. Following the first preliminary results, we suggest that regulation of steroids hormone levels by HKPR1C1 plays an important role in the accumulation of subcutaneous adipose tissue. We first proposed HKPR1C1 as the first candidate gene for lipedema, and we then published the other results supporting its important role in lipedema pathogenesis. New research should focus on finding other genes correlated to lipedema, as just said, focusing also on the other genes of the HKPR1C1 family. We are publishing the HKPR1C2 gene mutated as responsible. And they should consider also somatic mutation, not easy to study, but very important to know the illness. In conclusion, current knowledge allows us to confirm that the disease is hereditary. genetic and affected by many epigenetic aspects, the knowledge of which still needs to be deepened. We will do this together with the extraordinary strength that the Lipedema World Alliance possesses, with its founding members and with the various regular members who continue to increase the expertise of health professionals with their contribution to the benefit of patients' quality of life. In this regard, I would like to thank my colleagues who, with great commitment, continue to carry out our studies, which associated with those of the international scientific community are allowing us to give even more pertinent answers to the many questions that the disease and above all the patients who are affected ask us. I thank you for your attention. And I hope to done a presentation just common to the some field of the research, but with a possible conclusion with the collection of the various information to the same way to better understand the behavior of these cells, very original, like behavior, biological behavior. Thank you.
Thank you very much, Dr. Michelini. It was such an amazing presentation and also revolutionary. I think that it's very valuable that your research is conducted on normal weight people rather than the population of obese patients, because maybe overweight could be a bias for research in this sense. So it's amazing that you're finding all this stuff on people that do not have obesity or overweight. And also I see that there is something similar in what Dr. Simarro explained, because you both are speaking about vascular cause for lipedema, and it's very, very interesting that two totally different research, two totally different clinical experience have this in common. And so I think that maybe we can hope that we are on the right way to know some more about lipedema, and with the purpose of helping us with lipedema and to improve the quality of life. This joint effort of having all your expertise from you, Dr. Michelini, and you, Dr. Simarro, to help us to improve our lives is very emotional, and thank you so much to both of you. We have some questions.
The research start ever from the clinic observation. This is basilar.
This is something that we should say to the people that are saying that lipedema is not a progressive disease, because they are stating this a lot in many ways, and I don't think we have an answer right now, and that lipedema progresses only when you put on some weight. So there are a lot of causes, vascular, hormonal. There is a lot to learn about lipedema, and we are learning.
Very connected. Genetic, vascular alteration, hormones, they're very connected.
So it's not that simple as they say.
Inflammation. And inflammation, it's very important also in lipedema. Many of the women with lipedema, they always say, I feel like inflamed. The inflammation is very important, the subchronic inflammation.
So we have to write a letter to the WHO just to change the category as not a non-inflammatory disease, but as an inflammatory disease. So
there is always so much to do, isn't there, Valeria?
Yeah.
Dr. Michelini, as we're going to move into the questions, may we ask you to stop sharing your slides because then as
Yes.
you and Dr. Simarro are answering, everyone will get to see your faces in the fullest part of the screen.
Thank you.
So if we may give you a couple of questions. The first question is perhaps one for you, Dr. Michelini, as it refers to research. Can lipedema fat and ordinary fat be compared to diagnose lipedema? Or why can we not diagnose lipedema by looking at the fat?
The adipose cells of health tissue, of the tissue of the common obesity, and of the lipedema are very different, very different. For example, in the obesity, the common obesity, the volume of the cell is like the volume of the normal cell. The lipedema cell, the cell that constitute the adipose disease, the lipedema, is more increased respect to the adipose cells of the health tissue and of the tissue of the normal common obesity, until to the double volume. And this is the macroscopic aspect, but under the microscopic structural aspects, we observe a very high deposit of, for example, of calcium inside the intracytoplasmatic and interstitial space of the lipedema tissue, very different from the normal aspects, and that testify the action, for example, of some hormone action or non-action, like in lipedema, because, for example, the mutation of the genes AKPRS1 determine an increase of the functionality, not of the concentration. The concentration is the same of the progesterone, but the function of progesterone in these cases are more increased with the same serum level of progesterone, like in the health subject. And these are some observations very interesting to improve our knowledge regarding the illness.
Thank you, Dr. Michelini. I think, Valeria, you have our next question.
Yes, this is for Dr. Simarro. And you were very precise on where to press on the leg during the examination. So they are asking if a person has lymphedema also, and so it has a lot of fluid around the knee. Does that make a difference?
They have no pain. They have no pain. Not in lipedema, not in lymphedema, not in oil, not in any other diseases. This pain points only in lipedema, only in lipedema. I have seen a lot of women with obesity, with lymphedema, with any other pathologies, and they don't feel pain. But may tell something. Well, just a moment. You asked Dr. Michelini about how the fat is different in obese people than in normal people, than in lipedema people. Well, it's too long here to explain our last investigations with shear wave elastography. The shear wave elastography leaves us to know the elasticity in the three different layers of fat I show you that there are three differences in the leg, and the elasticity and the composition is different. So if you take a biopsy in one of these different layers, results can be completely different. And at this moment, usually, when you take a biopsy, what you get is the aspiration from a liposuction, and you can't differentiate between these three layers, and they are completely different. And we see it calculation. We can calculate the fibrosis of these three layers, and they are completely different in lipedema. And if you take a biopsy in these different three layers, the metabolism of the adipocyte is different. The extracellular matrix is different because the extracellular matrix is what gives the elasticity, and we are able to measure the elasticity. At this moment, shear wave elastography is using in cancer of thyroids, in cancer of mama, in cancer of prostata, in order to differentiate the fibrosis, and fibrosis means disease. We are at this moment making an investigation and watching the different elasticity of these three layers, and they are completely different. And I hope to finish this investigation to publish it. But I can tell you that we now can demonstrate that these different layers are completely different. And there are some papers published that say that they are different. So the biopsy of the fat of an adipocyte, if you don't know where of this layer it becomes, can be confused. And other thing that I would say that has not to be with this, but I have to say, is that everybody says that lipedema begins with the puberty. But there is one paper published with a children's hospital in the United States where they show 150 children diagnosed of increasing of the volume of the legs. All of them were diagnoses of lymphedema. But 15 years later, they look to those diagnoses and says, no, not all of them were lipedema. Remember, this is a children's hospital. And they say about 12% were not lymphedema. They were lipedema. And they, 15 years later, called by telephone to those girls and spoke with them. And you know what? They said, yes, now I am 20, I am 30, and I have lipedema. So they was children. They had lipedema, and this has been demonstrated. So that's very important. Lipedema usually begins at puberty, but not always, and this has been demonstrated, but very little investigated. Thank you.
Thank you so much, Dr. Simarro, and you've led us very nicely to our next question. We will squeeze in a couple of questions more before we finish. Several people have commented that they think they have lipedema fat underneath the chin, and that perhaps they have experienced this since they went through the menopause. I wonder if you both have any thoughts about whether lipedema can be found in places like the fat under the chin or elsewhere in the body.
Sandro, did you respond? Me?
Jose, in my experience, is to demonstrate this still now.
I agree with you.
Yeah.
I think that lipedema here, it's very difficult. I think that the lipedema can develop in the upper part of the body after the menopause, sometimes before, but especially here, really, I have seen thousands of women with lipedema, and I haven't seen that.
We can study also this aspect. We will study.
We are at your disposal with our bodies if you want to study our chin and in this body area. It's in general a question about if you think that lipedema is only in arms and legs, or do you think that lipedema can appear also in other body areas like the abdomen? You know, there is the big abdomen issue. So maybe we can extend the question.
Yes, to study still today.
I
We
think
have to study.
definitely, and we are at your disposal to be studied. So
To be
I
studied.
think we can have maybe a final question for our doctors, because you know your presentation were super amazing, but also very technical. But we also have a lot of patients listening to us today, and so I might ask you if you can take apart for a moment your super technical experience and give both of you a simple advice or your words directed to all the patients that are listening to us today. If you have a message for them, if you have any advice, I think every patient listening to us will highly appreciate some words from you both.
And we all thank the volunteers. They are the very authors of the possibility of improving our researches. It's very important just to improve the knowledge of this illness, very particular. The behavior of these cells are very interesting, very different from the fat cells of the tissue, the health tissue, and also of the obesity, very different.
We have aliens growing on our bodies. In Italian, you always say le cellule birichine, really, doctor. So, and Dr. Simarro, what about you?
You.
Do you want to deliver a message to our patients listening to us?
Well, within the lipedema is heritage, as Dr. Michelini says, but in his presentation, he has speak about the epigenetic, not only genetic, epigenetic, and that's important. The genetic is important, but the circumstance where a genetic express that genetic, the epigenetic is very important. And we think that one part of that epigenetic, of course, are estrogens, but inflammation too. And if you want to combat the inflammation, is the nutrition the most important. The anti-inflammatory nutrition, we think that the chronic inflammation is one of these part of the epigenetical trigger. And as you can avoid the genetics, you can fight again epigenetics and again this sub-inflammation. And this sub-inflammation for us is coming for something called leaky gut syndrome. And you can fight against leaky gut syndrome. So have a no inflammatory diet, but take care. Not inflammatory diet should not be a diet without a very important diet, una dieta, a carential diet.
Restrictive, you mean?
Yes, restricted. That's not good. You can't maintain in the long time a restricted way of eat. And then the Mediterranean way of eat, I think, is the best in this moment. So make a Mediterranean way of diet, make exercise, especially water exercise, very important, water exercise, not inflammatory diet, but take care. Sorry, but there are so much people that think they know what an inflammatory diet, and I have seen a lot of them that they don't know what an inflammatory diet is. But a no inflammatory diet and water exercise is the best you can do in the long term.
Thank you. Thank you. Such a great advice.
Indeed. And water exercise is certainly something that both Dr. Simarro and I are very passionate about. So thank you again for reminding everybody. So as we draw this wonderful session to a close, we'd like to remind everybody that if you missed parts of the presentations, you can watch this live stream again on our YouTube channel. So please feel free to pause, to play, and to catch up. And we have 2 more sessions coming up. So next week, we have on Monday a presentation by Dr. Philip Krupa, who will be talking to us about some of his work that he's leading with the Lipedema World Alliance. Indeed. Thank you, Dr. Michelini. We've been very pleased to take part in a process of a Delphi analysis looking for what is agreed about lipedema. So that will be a wonderful and interesting presentation about something that the founder community of LWA has been delighted to be a part of. Then a couple of days later next week, we have a presentation on the 26th on Wednesday, 2 days later, by Dr. Fauna Cordero and Dr. Wright. And Dr. Isabel Fauna Cordero will be talking about what we know about compression, and she has many fascinating thoughts. We will then hear Dr. Thomas Wright talking about the benefits of lipedema reduction surgery for reducing leg pain, improving mobility, and improving knee mechanics. So 2 very interesting and different speakers. Please join us next week in our YouTube on Monday and Wednesday. And thank you very much to everybody for your work as part of Lipedema Awareness Month. And we wish you a very wonderful evening and rest of the month. So thank you again to Dr. Simarro and Dr. Michelini, and good evening and goodbye, everybody.
Thank you.
Bye-bye.
Bye-bye. Bye-bye, everyone.